Okay, hello. I'm going to be talking about my soap note this week, and this is on a geriatric patient. Her initials are SQ. She is a 77-year-old female who is established patient and a reliable historian. SQ states, I am getting worried because I feel I am very short of breath and I am having some chest pain. SQ presents to the clinic unaccompanied for increased persistent dyspnea at rest. She reports intermittent atypical chest pain that started 3 days ago and reports dyspnea for the past 3 weeks. She's also can't catch her breath, she states, since having COVID 3 weeks ago. The patient was seen in the office 7 days ago for same thing, shortness of breath, fatigue, chest pain, and was prescribed doxycycline and prednisone. She states she has completed the 7-day course of antibiotics and 5-day course of prednisone and still not feeling better. Patient is typically very active, but now is unable to do her regular ADLs without exhaustion and fatigue, or with exhaustion. She denies any fever, chills, nasal congestion, cough, constipation, diarrhea, or vomiting. SQ's past medical history consists of anxiety, difficulty sleeping, GERD, and osteoarthritis. She is up to date on all her immunizations, including the pneumonia vaccine. She's had a physical annually, and she has done all her preventative care, including mammogram, DEXA, and colonoscopy. She's had no recent surgeries or hospitalizations. For her social history, she does not drink alcohol, use tobacco, or illicit drugs. She eats a healthy diet, drinks 8 cups of water a day. She usually walks about 5 miles a day. She lives alone in a 1-story home, and her late husband passed away 3 years ago. She has a good support system, and she's active in her community. For her review of systems, she reports malaise and fatigue post-COVID 3 weeks ago, but denies fever and chills. She denies any headaches, dizziness, syncope, however, reports sleep disturbances and feeling unbalanced recently during activity. She denies any changes to her vision, denies eye discharge, redness, or tearing, denies any nasal congestion, mucus discharge, cough, or sore throat. She does report intermittent atypical chest pain, reports tachycardia, chest heaviness, and heart palpitations. She also reports rapid breathing and dyspnea at rest and on exertion. She also reports labored breathing, but denies wheezing. She denies any changes to her skin, no hives, rashes, or lesions. She does report increased anxiety since having COVID, denies muscle pain, aches, swelling, or weakness, denies any changes to her bowels, denies diarrhea or constipation. And she denies any cervical lymphadenopathy or easy bruising. Her vitals today are a heart rate of 104 at rest, BP is 132/74, temperature is 98.2, and pulse ox is 98%. Her BMI is 22.3. Her vitals are then rechecked after walking around the clinic one time to see if there's any changes to her oxygen saturation. Her oxygen remains within normal limits at 96%. However, she does have an increased work of breathing and increased dyspnea. Her respirations are 24 respirators per minute, and her heart rate is 114. So last week when she was at the clinic, she had in office a chest x-ray that showed bilateral infiltrates in her lower lobes, and then she also got an EKG that showed just normal sinus rhythm. Upon physical examination today, she is mildly distressed. SQ appears very anxious, worried, and uncomfortable. She has a normal cephalic head, eyes are clear, sclera white, perla, tympanic ears or tympanic membranes are present in pearly gray in both ears, lips, and mucosa. Our lips and mucosa are pink and moist. Tonsils are 1+. There's no erythema. Uvula is midline, and she has a patent nose, no discharge. Her neck is supple, no cervical lymphadenopathy, Cardiac is S1 and S2 are present. There's no murmurs noted. She is tachycardic at rest, increased after mild exertion, and then there's no costochondral tenderness upon palpation. There is diminished airflow in her lower lobes. She is clear to auscultation in her upper lobes. mildly labored breathing, and use of accessory muscles during exam. She is alert and oriented, slightly off balance during exertion upon walking around the clinic, normal reflexes and tone in her upper and lower extremities. Her skin is warm and dry and appropriate color for her ethnicity. Extremities, she does not have any edema, no cyanosis, cap refill is 1 plus, and this is both in bilateral extremities, and then upper and lower bilateral peripheral pulses are 2 plus. So leading differentials for this patient are viral myocarditis, which is the inflammation of the myocardium without ischemia caused by COVID. Other differentials include valley fever, which is a fungal infection common in the southwest of the United States, causing dyspnea, fatigue, and wheeze. And then lastly, pneumothorax. So this is the 3 differentials here. However, due to the patient's recent COVID exposure and illness and her clinical presentation today, myocarditis is leading differential for her. So diagnostics for myocarditis at the clinic today is to repeat her EKG to see if there's any abnormal electric cardiac activity going on. Also, a second chest x-ray to see if there's any changes to pulmonary cardiac structures. And this can both be done in clinic. Labs are also drawn at the clinic for BMP to see if this is a cardiac or pulmonary etiology. C, reactive cardiac homocysteine to see if there's inflammatory markers in the heart, and then a CK-MK or creatine kinase myocardial bank to identify if there's any myocardial injury. And then we can't do this at the clinic, but an echocardiogram is also recommended to visualize the cardiac structure and function of the heart's chamber and valves. So, however, after prompting these diagnostics, I feel really uneasy about the patient's presentation. She has this look of impending doom, and my gut tells me that we need to send her to the emergency room. So treatment now consists of advising this patient to be picked up by a family or friend and driven to the emergency room because she needs a higher level of care that an outpatient setting can't provide for her. So she needs stat labs, stat EKG, echocardiogram. Education involves stressing the urgency of going to the hospital right away and following up with the outpatient clinic or myself within a week after her ER visit and have the hospital diagnostics brought in or sent over once they have resulted. So good luck, patient.